So it is my pleasure once again to welcome all of you to this 110th episode. Today we'll be talking about ADHD in adults. The rules of the game are simple. Everyone will be on the mute mode. The panelists can unmute themselves. The meeting is being recorded. We'll put it on the Facebook page, and we are also on the YouTube channel is also under construction, so it will be coming soon. So next slide, please. I'm handing over the session to Professor Dr. Tufan Pati sir. He's from Cuttack. He's the chairman of the program and behind the curtains man. So, sir, over to you.
Thank you, Dr. Alim. And I welcome everybody to this 110th episode of First Time Musings. And next slide, please. We are privileged to have with us two vibrant moderators of the program, Professor Amrit Patajoshi and Professor Alim Siddiqui. Dr. Amrit is well known as a EC member of IPS and an active member, and is Professor of Psychiatry in High-Tech Medical College. Dr. Alim Siddiqui is Professor of Psychiatry in Eras Lucknow Medical College, and he now has the treasury of IPS with him as the treasurer. I welcome both of them. And next slide, please. We have the honor of having Dr. Arun Khatri from Jamnagar as our chairperson. He is a consultant psychiatrist, past president of IPS Gujarat State Branch, and co-chair of Geriatric Subcommittee of IPS West General Branch. And he is the convener of Social Security Subcommittee of Indian Psychiatric Society. Welcome, Dr. Arun. And we have got also the Honorable Dr. Harish MT. Next slide, please. Harish M. Tharayalil of Kerala. He is Professor of Psychiatry, Government Medical College, Thrissur, and past president and editor of and treasurer of IPS Kerala State Branch. Welcome, Dr. Harish, and welcome, Dr. Arun. And change forward. The meeting is in the hands of Dr. Harish and Dr. Arun. Please take over and carry over.
Thank you, sir. Thank you, sir. I thank Dr. Tapan Bhatti, Dr. Amrit Patajoshi, Dr. Siddiqui for inviting me as a chairperson of this 110th Thursday Musing. I thank you very much. I'm honored to introduce our today's speaker, Dr. Arun Kandasamy from Bangalore. He is additional professor psychiatry, Center for Additional Medicine. He is affiliated with Center for Addiction Medicine, National Institute of Mental Health and Neuroscience, NIMHANS, Bangalore. His areas of interest and specialization is behavioral addiction, vulnerability, and youth medical health, psychological intervention in addictive disorders, course and outcome of addiction, physician and mental health. His publications are 50 national and international journals and 20 book chapters and monographs. His research and service projects are 21 funded and 17 non-funded projects. He is awarded and fellowships. He is awarded with Tilak Venkoba Rao Gold Medal in Psychiatry, Fellow of Ramchandra N. Murthy Foundation for Mental Health and Neuroscience, Fellowship of Young Psychiatric Asian Psychiatrist for the course on leadership and professional development of young psychiatrists at Bangalore by Asian Federation of Psychiatric Association. He is a fellow of Ramchandra N. Murthy Foundation for Mental Health Neuroscience. With this brief introduction, I request Dr. Harish to give a few words about today's topic. Over to Dr. Harish. Please unmute yourself.
Hello, audible now?
Yes, sir.
Yeah, audible now. Please.
Yeah, okay. Thank you. Welcome all of you to this wonderful evening program uh, organized by the Odisha Psychiatric Fraternity. So we have a topic that is adult ADHD, and I am sure most of us would be aware of this condition, but as practicing psychiatrists, we may not be very much diagnosing this condition because it's not officially endorsed in
Please
the.
stop sharing the screen. Okay.
Sorry. Okay, so it's not officially endorsed as far as I understand in our official classificatory systems, but it is something which is emerging as a new area. And hello, it's okay. I get some disturbance.
Yeah, please continue.
Yeah. Okay. So it's a new area, emerging area in the sense that it is yet to reach the kind of significance needed to call it a disorder as such. We are not clear whether it is a disorder or a trait or some kind of a personality kind of thing. These kind of issues are really there in this area, and also the comorbid issues with impulsive behaviors, substance use, etc., are also well known. And sometimes we see patients diagnosing themselves using these internet-based things, and maybe even coming and telling us that, sir, I have adult ADHD and do something about it. So that kind of a situation we are in. So I am sure most of the senior people may not be very much, I don't think many of us may be using this category as a diagnosis, but of course, we may be considering it in our assessment of the patient. So I think it is a real area worth taking up for a serious deliberation, and I hope today's evening will that discussions and the Dr. Kandasamy is an erudite scholar and an expert in this area and also in substance use. So I think we'll have a very interesting presentation and followed by good discussion. With these few words, I hand over the mic to Professor Arun Kandasamy for his deliberations and presentation. Thank you. Thank you, the organizers, for giving us this opportunity.
Thank you, sir. Thank you, sir. Thank you, chairpersons, both Professor Arun and Professor Harish. At the outset, I would like to thank the organizers, Dr. Tofan Bhati, Dr. Amrit Patadushi, and then Dr. Alim, for inviting me to do this talk today. I was supposed to do this in June, but unfortunately, because of COVID and other reasons, I couldn't continue with that. So it got delayed. I'm sorry for all the inconvenience. Let me see if I can do justice to whatever topic I'm taking today. Without much ado, let me move into the topic, ADHD in adults. Now, I had come across this problem long back, I think in 2005, 2006, during an exam situation where something odd was presenting to in the ward, and we were supposed to select cases like, and then there is something called as adult ADHD was there. It was very difficult to understand and very difficult to present. So we just did something and made certain diagnoses and put that in. Then once I started working exclusively in addiction, I've started seeing many of our clients coming with problems of adult ADHD. And that's how I've started getting interested in this area. In greetings from my alma mater, the Department of Psychiatry at MHANS. The objective of today's presentation is going to be on understanding the phenomenology and management of adult ADHD at the outset. And it is it'll be I'm sure all of us will be seeing symptoms of this kind. So I'm also going to be having a mutual learning by discussing with you all. I'm just presenting our practice and our views. I'm hoping to learn more from the audience too. Let me take a leaf from the approach of Russell Barkley, who's a scholar in the area of adult ADHD and adult ADHD per se. So here, I would like to divide my presentation into three parts, primarily knowing what is adult ADHD and knowing the phenomenology part of it, and then owning it. Let me come to that fact of owning it when I present, and how working with that is important. Let's start with knowing it. These are stats which we all know. ADHD was historically considered as a disease of childhood, affecting 4 to 12% of the school-age children. And majority of them, 10 to 60% of them, move on to having residual ADHD into the adulthood too. And this has been recognized, and further modification into the diagnostic criteria has happened with DSM-5 and ICD-11 also. The adult ADHD prevalence has been rated from somewhere from 4 to 5%, 4.5% per se. In most of the studies, this is the adult prevalence of ADHD. What was interesting was that three different cohorts. One is from the New Zealand's Dunedin cohort and the Brazilian cohort, and also the England cohort. These are birth cohort longitudinal studies. What they had found is they had found adult ADHD in adults 18 and above who didn't have any kind of ADHD diagnosis before that age. And that created further interest in this area, because there is something called as adult onset ADHD. One is residual ADHD, childhood ADHD moving on towards a residual ADHD. The other area is adult onset ADHD. Now, this is still a debated issue, because this doesn't come under any kind of nosological system at this point of time. What is more easily diagnosable in the nosological system is childhood onset ADHD moving on to residual ADHD per se. This is DSM-5's ADHD criteria. I wanted to fit it in one slide, so I had taken this slide per se. What happens is DSM-5 have divided into inattentive type of symptomatology. There are 9 criteria where they're in this group, and hyperactive impulsive type where there are 9 criteria are there in this thing. And under inattentive type, the expectation is at least 6 months, several of the symptoms will be present, but significantly, if a diagnosis of ADHD to be made in the children or in the adult, at least 6 children or adolescent, at least 6 of the symptoms, 6 or more of these symptoms should be presented, at least for the inattentive type. And the hyperactive impulsive type also the same way. 6 or more symptoms should be present to diagnose the hyperactive or impulsive type variant. And one of the very different thing which happened with the adult DSM-5 for the adult ADHD is that they have realized there are a group of people with ADHD symptoms are presenting in adulthood also. So what they have done is they have changed the criteria slightly. Those who are 17 years and above, 5 or more such criteria to be presented, either ADHD predominantly inattentive type or ADHD predominantly hyperactive or impulsive type. And if we are doing a combined type combination of both, 5 from here, 5 from there should be there. Again, 6 months, these symptoms should be present. Now, the interesting part over here is they have modified the criteria. Earlier, it used to be 7 years. Before 7 years, these symptoms should be present. And over a period of time, they've realized that many of the inattentive type couldn't be diagnosed because the problems start settling in after 7 years, basically. When they move from one middle school to higher school, more problems are coming up. So then with DSM-5, they shifted the criteria from 7 as age of onset to 12 years. The symptoms should be present prior to 12 years of age. That is what the DSM-5 had called for. And not only the presence of symptoms, but also at least in 2 dimensions of the person's life. It could be school related, it could be home related, it could be community related, church related, or any religious related dimensions. At least 2 of these dimensions, all these dysfunctions should be manifested in. So these are the changes which DSM-5 had brought in. Because DSM-5 had brought in, now we can diagnose ADHD in adults too, if we could demonstrate dysfunctions in at least 2 areas of the person's life. So there is no difficulty in diagnosing ADHD in adulthood at this point of time if they satisfy these criteria same. And some of the other aspect would be there is no other explainable disorders in terms of psychosis or mood disorder which could explain these symptoms present along. And then this has been divided to mild, moderate, and severe symptoms also. So this is the DSM-5's criteria, which was published in 2013. Now ICD-11 also is doing along the same line. Again, the age criteria has been kept as 12, and rest of it are more or less the same. There's no much difference across. Only thing what ICD-11 has said is there could be variation of symptoms according to the course also. That's the only line which could come over there. Now, what is very specific in the adulthood compared to the childhood is, it is not inattention alone. It seemingly like inappropriate attention, where what happens is in areas where there need to be attention, they are not able to give it. But there are areas where they are interested in something which changes in dynamic way, like for example, gaming or on gambling, wherever it is the medium is dynamic and the AV aids are very, very interesting for them, rewarding for them, they are able to do over concentration or hyper focus they are able to. So it is characterized by both lack of attention and also over concentration on certain areas, which is called as hyper focusing. In earlier time, it was only inattention. Now we are moving on to something different. And the problem is not that a patient with ADHD cannot concentrate, but that he or she cannot concentrate when he or she needs to. So that needs to be taken into account. It's not about simple inattention only. It's about inappropriate attention is what is coming up primarily. Hyperactivity. This is nothing but the brake is off. Again, here also there is a drastic difference from childhood to the adulthood life. In childhood, most often even in the criteria of DSM-5 also, it's like climbing somewhere or running around. The motoric activity is what is being given prominence. But DSM-5 itself is giving in bracket that hyperactivity in adults doesn't manifest as motoric hyperactivity. It would manifest itself as inner restlessness. And that inner restlessness is always about feeling of continuous agitation and not able to relax. And the mind keeps wandering, not able to say no to movement of the mind per se. And they need some strong agent to control themselves and keep their thought process or the emotional process to be under control. Which could be alcohol, cannabis, or any form of drug. And some have a better coping strategy in terms of doing exercise on a regular basis. To such an extent, they hurt themselves. They do running and they do all other stuffs, which are some way of relaxing their mind and able to focus on certain activities. So here, the core is about the brake is not working. The brake is off. In fact, the brake fluid is not available. This may manifest as endless talking, an inability to stop activities, rambling on and on. What is very important and is being discussed is in the clinics, Just a person, if he or she is sitting quietly during the examination interview, does not rule out hyperactivity. So the inner restlessness had to be elicited from them through an interview. Next comes impulsivity. Impulsivity is basically, the caption is just do it, like the Nike ad. So doing something without thinking, no back or forth, just come to my mind, I will have to deliver it. And this causes a lot of damages to their reputation and other aspects of their life, but they are not able to say no to it. And this is basically not able to postpone the need for self-gratification. And it quite closely related to the sensation seeking and novelty seeking also. Although the DSM-5 talks about 18 symptoms, which from the 9 on the inattention side and 9 on the impulsivity, hyperactivity type, Barkley actually had pushed in around 91 more symptoms, which could be say identified in these clients, and he went on to divide that into 3 dimensions under which all those symptoms could be put in. One is poor inhibition, say inability to inhibit the signals, and second is poor self-control. Third is executive dysfunction. All the 91 symptoms could be plugged into these 3 things. To go in little detail of it, what is poor inhibition? The problem is not knowing what to do, but not doing what you know at the right time, which is to stop before going on a tangent. So this is what is on the poor inhibition side. For self-control, what happens here is there's an inability to choose something other than your initial impulse. There is always an initial impulse when something is interesting or something is something which we like. But majority of them who has the self-control is able to say no to it. But these are clients who are not able to do that. Here, there is an inability to choose something other than your initial impulse. So you can get something in the future that you want more, or that is better for your long-term welfare or happiness. It's that immediate gratification is what given importance. The delayed gratification doesn't get weightage at all. That is the explanation of the poor self-control. Executive dysfunction. Again, I'm taking Barkley's model, where there are 4 different executive dysfunction which happens: non-verbal working memory, verbal working memory, emotional regulation, and planning and problem solving. Now, how we can think about it is, one is mind's eye. If I come across certain situation, what I do is I visualize in my mind about what happened in the past, and that gives me an idea whether I should take a particular course of action when some stimuli is being given to me. These are people who find it very difficult to do that because their mind's eye is not working. They are not able to go back. There's no hindsight is available for these people. Many of us do mind's voice in terms of we keep counseling ourselves. That's the mind's voice which happens. Like for them, that also doesn't work properly. And third thing is mind's heart. That is emotional regulation. Unfortunately, this is not given enough importance either in the DSM-5 or in the ICD-11. But in clinics, what we see is these are clients who have significant difficulty in regulating their emotions. In fact, what happens is they find it difficult to even recognize emotions, what kind of emotion which they are going through. Because they are not able to recognize, they are not able to regulate on time also. And that results in aggression or whatever emotion happens, that's in extremes. And the when all these 3 things are going wrong, the ability to plan and solve problem is also not working properly. So these are the 3 areas in which these dysfunctions happen. I can share with because it's 90 it's a list of 90 issues, so I didn't share that here. Not only that, that's what Russell Barkley, DSM-5 and ICD-11 has said. What we also see in our clients is that they have significant deficit in motivation and ability to sense reward. These are people who are not able to sense rewards, and they need heightened sense of reward to feel it, and to motivate themselves to move forward with that. And it's when attention deficit is being pushed in the front, this is usually forgotten. And adults with ADHD have reduced response to rewards and are less motivated to engage in and follow through on everyday activities. That's why they are called as world's best planners, but poor finishers. And this definitely need to be considered when we are treating them also. Now, this is another concept which is gaining more important these days. The clients with adult ADHD, what we are seeing in them is they are extremely emotionally sensitive. Even a smallest rejection which happens in the environment, or if they perceive it, they amplify it inside their mind, and they take it very, very personally, which results in rage against self or others. Whether they internalize the rage or externalize the rage, it happens. When they internalize the rage, self-harm attempts and suicidal attempts happens. When they externalize the rage, anger and aggression towards the others happen. Whoever is a significant other person. This is very commonly associated with adult ADHD. Something being present in other areas also, but when a syndrome of adult ADHD is considered, rejection sensitive dysphoria is one of the major component which needs to be evaluated. Now, those are the phenomenology which you will see in these clients as the areas of the characters of adult ADHD. Now, this results in certain areas of difficulty. One is about time blindness, which is they are not able to manage their time properly. And that results in poor planning and poor goal setting. They are very, very poor in organizing themselves, which again results in poor problem solving. Their inhibition doesn't work properly, which results in poor self-discipline. And they have very poor self-motivation. The drive to do things by themselves is less in this group. And they have poor self-activation or concentration and alertness. Now, these deficits, where all it causes impairment is every possible aspect of their life, whether it is home, work. For example, work, they just keep changing their work. They're not able to sustain their work for a longer period of time. The nature of work keeps changing. They start one work, but then they get disinterested. Their social life is affected because of these natures. Because they just take something and they get into friendship often, but then they are not able to handle them, and then they get into interpersonal issues with them, and then they move out of it. These are people who are seemingly having multiple love affairs, multiple sexual affairs, where they lose interest very frequently, and then they keep moving on to different partners. They are very poor in money management. They have very, very poor driving skills, and they are poor in executing their daily responsibilities. So every part of their life could be affected. Now, this is relatively including everything, but each individual might have a specific set of difficulties based on their environment, how nurturing their environment is, and how they've learned over a period of time during their developmental phase. The dysfunctions might be more in certain areas and less in certain other areas. So the phenomenology and nature of impairments are found to be varying across different age groups and the course of adult ADHD also. Now, what happens with the younger ages when they have adult ADHD symptoms at 18? they are going to have difficulty in terms of learning skills. They may not be able to learn skills adequately because their mind doesn't work properly, and their mind is not focused on the task in hand. But when we see ADHD clients coming at 40 and 50 and 60, they seem to have already established skill set, at least in their work environment, and they have achieved certain level of functionality, but they have difficulties in their personal life with which they are common. The common comorbidities. Anxiety, seemingly very commonly comorbid with this group. 50-40% of them have anxiety comorbidity. Depression, again, around 20-40% of them. Drug and alcohol abuse, 9-45% of them. Personality disorders, 25% of ADHD children do have cluster BPD symptoms also. And interestingly, non-communicable disease is something very commonly noted with these people because of poor sleep, poor eating habits, and also poor lifestyle habits. They get into non-communicable disease quite often. One of the study which we have recently done, we could see the difference between alcoholics and alcoholics with ADHD. We have found that cardiac risk factors are very high in the group which has ADHD than the group which didn't have ADHD. This is a small work which we have done, and we found that in our group, around 250 patients we took, and more than 50% of them had likely ADHD. And when we made the criteria little stricter to diagnose ADHD, all these are adults actually. Almost around 20% of them had ADHD, and it was very significantly higher in the group which had early onset addiction, which for us early onset addiction is under 25. Those who have developed addiction under 25, they had a higher chance of having inattention domain in them. Now, this is another study which I've talked earlier also. All of us need to be aware of this particular study, which looked at the longitudinal birth cohort of 50 years. There are 3 different disorders they looked at in these children. Almost around 1,000 children have been followed up. One group is on the externalizing disorders, which include ADHD, contact, ODD, and substance use disorder. The other group had internalizing disorders. The other had thought disorders. Now, the interesting fact is that the live diagnosis of mental disorders, when they have been followed up for 50 years, what has been noted is most of them had another comorbidity, which is outside their family. If they have been internalizer, they had more externalizing comorbidity. If they are externalizer, internalizing comorbidity. If they had thought disorders, which is psychosis and odds, they had other set of comorbidity. So what is the learning over here is there is no loyalty to one particular, say, for example, if they have been diagnosed as externalizer, which include ADHD, CD, ODD, substance use disorder, it not necessarily mean that they will be continuing to have same kind of disorders. They can have other disorders also. And this is very evident in the ADHD group, which we talked about. Now, when it comes to differential diagnosis, this is one of the points which was raised also about what is the difference between the ADHD and certain other disorders which are presenting with similar problems. For example, substance abuse. Generally, how to differentiate it is because of substance abuse, and how to differentiate it is because of ADHD. Majority of the time, the substance use abuse related problems usually happens when there are intoxication or withdrawal related situation. They are just state dependent. They are not trait dependent. But ADHD seem to persist even after the intoxication phase or the withdrawal phase is over also. They continue to have problems. Again, antisocial personality disorder. ADHDs do have lying and cheating on certain aspects of it. But the pervasive disregard and violation of rights of others are not seen in ADHD group. It is very commonly seen in antisocial personality disorder group. Then comes to borderline personality disorder. This is one of the most difficult differential diagnosis towards adult ADHD. Now, some people argue that they both are the same spectrum, and some people say no. What is being seen is when both of them seen individually, they do have impulsivity, they do have emotional dysregulation. If a patient is being diagnosed with both borderline personality disorder and adult ADHD, they seem to have even higher rates of impulsivity and the emotional dysregulation issues. So how do we differentiate between borderline personality disorder and the adult ADHD? What's very commonly seen is in borderline personality disorder, the core is about the self. The self and identity issues, which are very, very prominent, is not very commonly seen in the ADHD group. Both of them do have impulsivity, but ADHD impulsivities are more motoric, and borderline impulsivities are basically focusing towards the inability to recognize cues from the environment and just just shouting out. And emotional dysregulation seemingly present in both the groups and more on the borderline groups as such. Again, there are issues like hyperthyroidism and seizure disorder. They also might present like ADHD, but it's very easy to differentiate with them. One other group which was also need to be looked in is the bipolar spectrum disorder or bipolar type 2 group. Now, how do we differentiate that? Because there is mood fluctuations and mood emotional regulation issues even present in ADHD, but those are within a day, and it continues throughout. But in bipolar disorder, usually that is episodic, right? It might be little difficult when it comes for cyclothymia and other diagnoses in the which used to be there in the past. Now, that is an inherent problem. But in general, the bipolar disorder do have episodic mood impairments, but adult ADHD impairments in terms of mood and emotional regulation continues throughout. Where do we come across these clients? Majority of them land up in the addiction clinics, some on the marital and family counseling because of their flamboyant lifestyle. Referrals happens from workplace, the HRs, when they find it very difficult to handle these clients, and some happens from the pediatric clinics and child and adolescent psychiatric clinics. Let's move on to screening of this group. This is an ultra short screening list, which was done by the Sandra Cui Ungroup. What Sandra Cui has done is had 3 questions, each focusing on one of this, like one on the hyperactivity component, which is generally feeling restless. The other is on the impulsivity component. Do you generally do things first and then think about consequences? And third is on the concentration or inattention problem. If any of this says yes, if there is an answer of yes comes in, and then the next question asks is, have you always had this? If again yes comes in, we need to consider ADHD and should be looking further into the diagnosis of ADHD. This is the ultra short screening list. This has not been validated, which Sandra Cui herself agree. But then this is one of the very short instrument which can be used in the general practice per se. There are other nice screening and diagnostic tools which are available. Commonly what we use the ASRS, Adult Self-Report Scale. And there are others like Barkley Adult ADHD Rating Scale, Connors Scale, and DIVA, which is Diagnostic Interview for ADHD in Adults, is the diagnostic tool per se. Now comes the, till now we talked about the know it part. Now we are moving into own it. Okay, these are people who are found to be having troubles. They never knew what was their trouble. They were always being called clumsy, not regular, careless. They are always called as somebody who was clown, foolish, and not responsible. All these titles have been given to them. So when they find a reason why they are like this thing, usually the emotional reactions are a relief. That's the first thing. Like, oh, okay. All these while I have been named and shamed because of these problems, but really it is not a problem because of me. It is something which I have as a disease. Now there are other also there, like relief and joy can be there. Some people can be angry why it has happened to me, and some people are grieving about how much they have lost in their life. Some are even in denial also, that this is not my problem. The most important part of it over here is this is an explanatory model, and it's not an excuse regarding whatever they have done. So this needs to be owned. The adult ADHD and its consequences need to be owned by the client themselves. It gives an explanatory model, but it's not given excuse. Having ADHD is not your fault, but accepting it is your responsibility. So this is what the own it part of it. Now let's come to the work with it. There are different things under work with it. Let me first give my take on the management model per se. Treatment of adult ADHD, I equate it to learning ballet. What are things which are need for learning ballet? First thing is motivation to learn ballet. Two is the infrastructure, which is the floor and the kind of dress and the attire. The third one is about practicing, regularly practicing it. Right? These are the three things which are essential components of components for learning ballet. If we equate it to treatment of adult ADHD, the motivation, I would say, should be generated through the psychoeducation. A proper psychoeducation is generated through the psychoeducation part of it. Two, the infrastructure, which is nothing but having a nice floor, because a ballet cannot be learned in an improper floor. The floor has to be proper, otherwise they will have fractures and they will have to have the particular attire, right? And that is achieved through medication. Third, the practice, the regular practice, that should be achieved through psychosocial intervention. So there needs to be a combination of all these three and not one. Although medications have majority of the response, but a combination of psychoeducation and medication and psychosocial intervention is what going to give us the maximum outcome per se. So let's see what is the treatment focus and how the therapist attitude should be in terms of adult ADHD. This was discussed in 1996 itself. One, the treatment focus should be more of educational and supportive, right? Because these people are being named and shamed all the time. So now they have to be receiving a proper educational approach. Next is, okay, I have generated insight. I have had problems in my different dimensions of my life, and that could be explained through the deficits which I have in these areas and how I have reacted to it. You will give a reframing the model where you will link the problems with the deficits. So linking insight to the action. And then very, very practical oriented approach should be taken over here. Here and now approach, rather than thinking of too much. Specific goals need to be discussed with them. So goal-oriented approach and solutions. The focus should be what solution we are trying to achieve. This is the ADHD treatment focus and the therapist attitude required as described in NADU in 1996. So what is psychoeducation over here? This is an indispensable part of the treatment. As described by Dr. Harish, people come with a lot of knowledge over there. We find it difficult to satisfy their own curiosity and inquisitiveness. So a proper psychoeducation is an indispensable part of the treatment. They are in an inexhaustible need for information, because this is something as an explanation which is being given to them for all their deficits. So they would want to know how they can correlate on each of these things. And not only them, even the partners and the parents need to be properly educated, because if the intervention needs to be successful, then these are the major stakeholders who need to be cooperating into that. And we really need to guide them into digital resources which are more authentic. For example, some of them like Cadra is very good. chat is good, and ad resources and ad warehouse are very good resources for them to go and read about it, rather than going into all kinds of there are different websites where a lot of bad things have been said, and about diagnosis or treatment which has come up. So it's important for us to give even understanding that there is a need for a digital resource, and we guiding them to move on to more authentic digital resources. In fact, I was curious to see even in Hutchison Hunter also, now they have started talking about Google Patients and how digital resources need to be modified. Let's go into the medications part of it. Now, the most important treatment in adult ADHD and adult ADHD is stimulants. Stimulants have been found to be effective most often, almost around 50 to 70% of the time. The client responds to stimulant within first few doses. It is found to be effective when compared to placebo and even other non-stimulants. Over a period of studies, over a period of 6 months, they found it very effective. There are so many myths and misconceptions which are there about stimulants, whether they are addictive, whether they will cause different other problems, with whether people with addiction can be taking this. These needs to be clarified, because it's very well known that not all the patients who have been prescribed stimulants are abusing it. When it is being given in a clear prescription format, they are able to follow it and they are able to see the difference in their life. So these myths and misconceptions need to be clarified. What is available in the country is methylphenidate, and it is available in 3 different formats. Immediate release, sustained release, or even OD formulation is also available. And the other one is Concerta OROS formulation. Concerta has both a combination of the immediate release and the sustained release. Almost around 22% of the concentration is immediate release, and 78% is on the sustained release as such. Usual dosing, whenever we start with the immediate release preparations. But the problem with immediate release preparation is that the drug effect wanes off very fast. So we might have to keep giving, like say 4 to 5 times the dose needs to be repeated in order to sustain the effect, which is not viable for us. So we go for, after looking at their tolerability, we convert into sustained release preparations. And usually sustained preparations 10 and then 20, 30, and 40, or 18, 36, and 54. With Concerta, we start with 18, move on to 36, and 54 also. Some people, we go up to 60 milligram and even beyond, which is based on the need of that particular client. But usual doses 40 over here and 56 over there, 54 over there. Very few absolute contraindication. One is pregnancy, and there is psychosis currently present, not the past thing. That is a relative contraindication, but absolute contraindication is the current psychotic episode. Third is congenital dysrhythmia. Arrhythmia-prone people, we need to be very careful with it. These are the 3 absolute contraindications. Relative contraindications include looking at issues of, again, cardiac conditions, uncontrollable hypertension, if there are tic disorders, if there is a treatment-resistant psychosis, and other aspects which we need to take into account. We really need to apply both symptom checklist and the side effect checklist in them periodically to keep to ensure the safety of the client, and for us also it is safe to prescribe certain doses in certain format. Now, when we are doing this, it would be good to look at what is the effectiveness, and when the effect of the stimulant wanes off also need to be looked for. Some of these clients are very, very good in terms of ability to say until what time in the evening it works. Because of learning from them, what we realized is OROS, although it is being touted to be working for 12 to 16 hours, unfortunately, we don't see that in the clinics. So even for OROS also, we might have to do two doses, repeat doses need to be given. And in site release preparation also, we give 2 doses. Slow building of the dose, especially if if they are older adults, need to be looked at. The risk of abuse is relatively less if it is being properly diagnosed and properly prescribed with the triplet prescriptions, and the follow-up dates are properly followed. Then the risk of abuse is quite less. Even in people with substance use disorder, it has been found that they don't seem to be abusing the methylphenidate prescription as usually expected. Non-stimulant, the one medication with maximum amount of evidence is the atomoxetine. Now, it ranges from, say we start with 10 milligram, 18 milligram, and then hike up to 40 to 60 milligram. Usual dose of us is usually we keep it as 40 milligram, because after that they are not able to handle the doses because of various reasons. Like it could be sexual side effects, it could be gastrointestinal side effects, it could be some people presenting with vague anxiety related symptoms. So generally, it's being kept between 40 and 60 milligram based on the tolerability level. The one point over here is it needs at least 4 to 6 weeks for change in any form of symptomatology. Quite a few times, the client will not be able to sense whether this change in the symptomatology is a course of the illness or it is because of the non-stimulants itself. This commonly happens with atomoxetine, and they just stop the medicines also because they don't feel that the medicine is effective. Other non-stimulant medications which have used are bupropion, guanfacine, modafinil, venlafaxine, reboxetine. Especially the rejection sensitive dysphoria, reboxetine and clonidine are being used, but their evidence base is very less, and then they are being used as second or third line drugs. Again, polyunsaturated fatty acid supplements, omega-3 fatty acids, it's also being given as an add-on prescription to the anti-ADHD medications. Treatment of comorbidity is something which is very important, because comorbidity is a rule than exception, and most majority of them have comorbidities. Treatment of those comorbidities is going to eventually help in the improving the dysfunction and impairments in certain dimensions of their life, and also in general improving the quality of life of these patients. Now, with depression, usually SSRI is being given, but again, going slow is important because SSRIs plus stimulant combination may not be very, very light, but then for some people, unless we give that, we don't see much improvements. Like the other common prescription is a combination of mood stabilizer and stimulants. This either in bipolar affective disorder or borderline personality disorder, we do use this. If the bipolar affective disorder is like type 2 bipolar affective disorder, then we use lamotrigine plus stimulants or lamotrigine plus atomoxetine. If not, then we use valproate also. Now, in the form of non-pharmacological intervention, the generic terminology which is used is cognitive behavioral therapy, and it is there are RCTs which have been done and they are found to be useful. Usually, it is used as an adjunct to pharmacological therapy. And there are other kind of therapies which are neurotraining, which is basically biofeedback trainings. And also there are things like brain gyms, where games have been used. The kind of cognitive retraining has been gamified, and brain gyms have been used. Again, the evidence basis is quite less at this point of time. Now, going into a little more detail of the psychosocial intervention, what's more important is we need to see which dimension of symptom is predominantly present in a client, and what is their problem. Is it their self-esteem is a problem? Are they too perfectionistic, or they keep procrastinating their whatever aspect which need to take? Whether they find it difficult to handle distress, and they have issues with anger management. Many of them do have internalizing symptoms like social anxiety. Interpersonal efficacy is very poor in these groups. Self-related identity is an issue. So each of this need to be handled separately. Whether we want to call it as cognitive therapy or behavioral therapy, doesn't matter, but each of these need to be handled separately. Now, one of the resources which I usually use and use this with my clients and also give them to read is the Center for Clinical Intervention, Western Australia University. I've given a link also. I can send it to people if they are interested. There are different modules on each of these skill sets. Say, for example, 6 to 10 sessions of interventions, which are actually manualized, and it's very easy to administer also. So very, very useful for our clients if we do it. There are certain self-help tips. Again, I'm taking from Russell Barkley's, as an excerpt from Russell Barkley's book. Stop the action, buy some time before you respond. Again, it's very difficult, but this had to be trained over a period of time. And then see the past. Whenever you are to respond, see the past, which is the mind's eye, which we talked about. Ability to visualize what happened in the past, right? So that you can see what's coming in the future also. Say the past. If you're finding it difficult to visualize it in your mind, keep talking to yourself inside the mind, right? So that you can use that to analyze before deciding, right? And also develop rules for the future. And the key information which you need to remember need to be kept as reminders in front of you. It could be in your mobile, or it could be a sticker in front of your monitor, or the rules need to be written in the board, something which is visually available for you to remember. So externalize the key information so that they are cues to induce your memory and make you to remember them. Feel the future, that what kind of changes are going to be brought down by certain behavior and what is going to be my benefits. Feel the future, and that may help in staying motivated. Break it down and make it matter, because when an activity is being given for them and ask them to deliver in a complete manner, they find it very difficult to do it. So for them, it has to be a whole activity need to be split, each split into 4 or 5 smaller activities. Each should have its own reward, whether it should be coffee, or it is mingling with somebody, or a break, or something else. It has to be broken down in multiple things and then put together. They will be able to deliver what they are supposed to do with it. And use different methods externally to do problem solving, external aids, external people to help problem solving. Then have a sense of humor. If you're making mistake in front of people, accept that you are imperfect and get on with your life. So this is more matured way of accepting that I have a problem and moving forward with it. Now, this is something which I commonly use. Generally, what happens is when we are having reduced resources within ourselves, we find it very difficult to handle stress which is coming to us. Unfortunately, some people go to some form of addictions, substances. It could be alcohol, it could be cannabis, it could be anything else. Now, there are others who use running or exercise or cooking or photography, whatever it is fun for them, right? They should have something for themselves. Positive alternative behaviors should be there. They become buffer when there are stress which is coming from outside, and the client can use that positive alternative behavior and the buffer which is provided by the positive alternative behavior, and reduce the decompensation which happens during the stressful phase. Family intervention is very important, because they since these clients' motivation keeps fluctuating, we need family to be there around to help them out. We need to define the problem clearly with them, and we also need to handle their expectation, because they might have different expectations, but we may not be able to deliver fully. Handling interpersonal issues among them, finding somebody else who can do it. Say, for example, the client may not come to you. You can find somebody else in the environment, in the family, who can do your job, can come back to you and learn from you and go on administer that over there. Handling lapses and relapses if there is addiction which is involved, and ensuring the commitment to the treatment process. ADHD coaching. Again, this is something which is picking up. It's more often present in Western setting. It's also picking up in India, where there are people who work with them as coaches, like personal trainer for physical activity. These are personal trainers for mental activity. They focus on self-sufficiency in everyday life. And this happens through mentoring on one-on-one group. They even coordinate all the interventions which is being delivered from the different dimensions. The last one is about challenges faced by therapists. The cooperation keeps dwindling after the heroic phase often. Initially, when they know that, oh, this is all happening, so it is very novel, they will be able to cooperate better. But then after 2 to 3 months, when they don't find much difference, their cooperation will come down. So we need to keep motivating them. And it is also very difficult for us to see there is recurrent crisis in the same area where you have worked with them. The problem is there is no hindsight and foresight that will happen. This will result in both countertransference and transference issues with the client itself. And managing the expectation of stakeholders is very important, because it's going to be detrimental if it's not being handled properly. But then they always would come up with one to our side and one with the patient side. It is always a problem. These are the challenges usually faced by therapists. Summary: the syndrome of adult ADHD is both a disorder by itself, and it is also vulnerability in terms of substance use and other aspects, and it becomes comorbidity also. It is important to identify and treat them appropriately. A combination of biological, psychological, and social interventions in order to reduce the dysfunction and improve the quality of life is important in this group. My suggestion towards reading is these 2 books. It's available, at least Taking Charge of Adult ADHD, everybody should read, because that's something have most of the information which I've talked about in a nutshell. And this could be even given to clients who are able to a little more sophisticated and looking for more reliable source of information. These 2 books I would suggest as a reading material. Thank you.
Wonderful, wonderful.
Thank you so much, sir. A really nice presentation.
Thank you.
Over to chairpersons for their opening remarks.
Yes, thank you, Dr. Arun. It was a nice presentation. And I think we have learned many things from childhood ADHD to now the adult ADHD. Many queries were there, and we have resolved most of them. I think most common would be the perception, hyper-focus, inappropriate attention, and inner restlessness will be the key points to identify from the adults. And what you said is ultra short screening test. That is very important to screen the patients in OPD sessions in the private institutes or private consultation clinics also. And as you said, the education, individual, family, and the support from the society is very important for them to handle their symptoms and the outcome. As you said, the multiple management strategies will help them to handle their frustrations and their problems. There are many challenges which we have to face, and we have to understand, and we have to improve to control their symptoms and the outcome. Thank you very much, Dr. Arun. It was a wonderful session. I would request Dr. Harris to say more.
Hello, welcome. Thank you, Dr. Arun. I think that was a very wonderful and clear presentation. And I think you have covered the topic very well. I would like to ask a few things. One is that what is the gender ratio like? Is it more common among male, female? Is there any difference? And also, I had a feeling that maybe males are more likely to get diagnosed as adult ADHDs, and females are more likely to get diagnosed as borderline. Kind of, so that kind of situations. Does it really happen in clinical work? Because when I going through that kind of profile which you have given about the
its patients. So,
Uh,
so
Yes, sir. I think this is one friend. I think I missed it to present that concept. In fact, the ratio is quite skewed. Some studies says 1:2, which is very rare in the childhood ADHD. 1:2 is present in say male 1 and female 2. The ratio of male to female ratio is 1:2, and some say 1:1 also. So there seemingly general gender equality in adult ADHD presentation per se. But again, there is always a risk of when it comes for diagnosing personality disorder, we end up in diagnosing ASPDs men and histrionic or borderline PD in women most often. We are not very comfortable in diagnosing the certain diagnosis in certain gender also. It is possible that these two are very, very difficult to differentiate also. So it's possible that many would get borderline PD and not ADHD part.
okay, thank you. I think we'll go for to the other questions. I think
Yeah, there are a host of questions in the chat box. Dr.
lot
Arun,
of
if you went through any important question that you'd like to take from there.
Just a second, I'll have.
Yeah, I myself and Amrit will put it to you. Amrit.
Yeah.
there are so many
Lot of questions, but first we'll come to the differentials in terms of diagnosing ADHD. So 2 or 3 questions. I'm just trying to put all few questions together so we don't have to take too many questions. So how do we differentiate between ADHD, adult ADHD and bipolar affective disorder, as well as borderline personality disorder? So that's one question that's come.
Again, bipolar disorder. In bipolar disorder, generally both places emotional dysregulation is being seen, but in bipolar disorder it is episodic, and it is more state driven. But in the adult ADHD diagnosis, most often this is present within the day itself 4 to 5 times, and it is present throughout. This is a one way of making the differentiation. As I pointed out earlier also, the concept of cyclothymia, ultra rapid cycling thing, it's always going to be an issue. One way of resolving is looking at other factors in terms of issues with respect to family history of these things might help us in identifying whether there is whether the diagnosis could be pointed towards bipolar or the ADHD component. What is more difficult is borderline personality disorder and the adult ADHD. Now, both of them have impulsivity, both of them have emotional dysregulation, and both of them have self-related issues as such. Like, but in borderline, the core is about self and identity is a problem. Now, that is not a major presenting symptom in ADHD. That's number one. Number two is the impulsivities are a little different in both groups. In ADHD, it's more of motoric impulsivity which comes in. And when it comes for the borderline, it is more of inability to take cues from the outside and able to modify oneself. So that kind of impulsivity commonly happens with that group.
And how does it overlap with ODD and complex PTSD?
Yes. Now, ODD is something which is a very common comorbidity with ADHD. And adult ADHD, usually there is improvement in this ODD components towards the later part of the adolescence, and then it manifests in different other ways. ODD is very specific, and this that's about not able to the stimulus when it is not acceptable, it is reacting to it in a different opposite way. Here it is very different. It is about the mind wandering which keeps happening to them. It's not about opposing a person and being defiant over there. So that's very easy to do. But the second disorder which you talked about, sorry,
The question was regarding complex PTSD, which can have.
Yeah, complex PTSD. See, by virtue of being a little different, these kids are more prone for traumas also. different kind of traumas these kids are also supposed to undergo. And by virtue of these symptoms, they are vulnerable to have traumas of different kinds in their group. But complex PTSD is more to a problem in differentiating from borderline rather than adult ADHD, because complex PTSD more often presents like borderline, or we might mix up with that, but not specifically adult ADHD, because adult ADHD is pervasively present in different other dimensions also. But complex PTSD is around the dimensions of where these dysfunctions are majorly present. In that way, it's a little easier to tease out.
So
Between complex PTSD and borderline PTSD, it's always a problem.
Okay. So a patient is coming with, suppose, anxiety symptoms, and another patient is having anxiety with adult ADHD. So what will be the different manifestation of the anxiety? How will anxiety present differently in alone and with ADHD flavor?
Okay. So the anxiety, you're talking about anxiety alone and anxiety with ADHD component.
Yeah, how the flavor, how the presentation phenomenology will change a bit.
Right. Now, the anxieties in general with these disorders are going to be around the ruminations of the future, right? The worries about the future and ruminations around that area is predominantly the anxiety disorder part of it. But the ruminations in the ADHD component is not primarily that. It is going to be similar because most often they are comorbid also. There's a significant amount of comorbidity of anxiety disorder is also present. But what happens is the internalizing component, if it is there as a part of what negative environmental stimulus which has caused them, will be very evident. If we go into the details of that anxiety, the origin of this anxiety and the phenomenology, it will be attached to the response from the how there is the meeting of the externalizing disorder and the environmental stimulus, how that resulted in the response. We would explain the anxiety symptoms. I conceptualize this way mostly.
Okay.
So there's another question. We are looking at the differentials and how to I think that's the most important aspect. Can normal adolescence turbulence crisis mimic ADHD, particularly in the context of recent pandemic situation and changing patterns of parenting, as well as the overuse of mobiles and all?
Yeah, screen time.
We see a lot of people now coming with those things.
Absolutely.
We generally call adult ADHD as extended adolescence.
Yeah.
Whether it is 30, 40, 50, 60, this is nothing but adolescence extending on to adulthood. Chronologically and physically they are adults, but then mentally they remain adolescents. And that's how it comes up. And this is a very important point which you brought in about the COVID situation. Now, the COVID situation has been a very, very important naturalistic experiment which has happened. The kind of buffers which we all had has been removed, and we have been forced to come up with our original personality without any kind of any kind of buffers which are available. So majority of the time what happened was the kind of buffers which were available is either gaming or some kind of utilizing the gadgets. That is what was available to them. So quite a bit of clients came up with gaming related disorders and gambling also we have been seeing quite often. That's online gambling has been commonly present. And these clients, we are able to see they have ADHD traits which are coming up in them, like especially the components of inattention, which is very commonly seen. Now, majority of them, if there was enough buffers, if there are enough environmental buffers available for them in terms of them going to schools, meeting their friends, having fun around that, those rewards, if it was there, the amount of dysfunctions which which the inattention which they have. All of us have inattention. I don't think so anybody has a perfect attention over here. But some people have a differential dosing of inattention. Those who were there in the fringe, they had become properly inattention. What I've been hearing from the child psychiatry, I've been discussing with them, like, are they seeing more after the COVID? Luckily, they are saying that it is not as severe. They seem to be adopting to the environment, able to go to the school. The quantum of problem they expected is not the same. It is there, but it is not to that extent they were thinking. Maybe they will, when they've been given the right buffers, they will be able to manage better.
Okay, and regarding the medication, so you said stimulant. So how long to give? Risk of addiction, and when you suddenly stop, is there a crash? So how long to persist with that?
One thing is that suddenly stopping, the crash is not being expected. That's what most of it. But usually we taper it and stop it. Now, there's one component I always do is, when it comes to adult ADHD, I predefine for what I'm giving the stimulant. I look for specific reason why they want to be started on stimulant, and the client and I get into an agreement that this is a symptom for which this is being started, and now when this being started, let's keep monitoring what kind of improvement is happening. Now, whether this alone is enough, no, I wouldn't agree with it. I would want to add some of these psychosocial interventions also. Now, if both are present and they are able to learn the skills which they have not learned or they have lost in transit, then we try to taper it and stop it. If they are able to manage well, we can go ahead with that. Generally, it needs to be continued at least for a year for them to learn or unlearn the effective coping strategy or not effective coping strategy. Now, I do have been following up people who for 10 years now who are on stimulant, who are doing extremely well without much difficulties. And I can vouch for some of my clients who are actually stealing vehicles around over here, when they have been brought and treated, looked at the ADHD comorbidity and treated well. Now they are doing extremely well in their both in their academics and their personal life also. Why should I disturb it, right? I don't initiate that conversation, but if the client initiate that conversation, I discuss with them and make a call how we'll go about tapering it and stopping it. Now, for me, it is like diabetes and hypertension. If that is, it is similar to that. If it is a problem, it has to be treated. And there are monitoring which needs to be done. Nobody is saying no about it. Like, for example, insulin resistance need to be looked at, hypertension need to be looked at, pulse rates need to be looked at, ECGs need to be looked at. That will be done. But if there is a need, it will be continued indefinitely also. There's no clear guidelines on that, sir, I would say.
Dr. Arun, so what about any possibility of the effect waning of like tolerance and maybe need for dose escalation? Such things do happen? Or?
No, sir. Majority of the clients are able to, when we fix on a particular dose, they are able to stick on to it and they are able to see the difference. Now, this is where the most important part of that ADHD diagnosis doesn't mean that stimulant directly. It is also about understanding that why the stimulant is being started. Stimulant is not going to be a panacea and it's not going to change their problems. For example, if they have a problem with their wife, and if they are not able to focus with the wife, not able to give importance to the wife, and not able to take responsibilities at home, now these things, to an extent, the methylphenidate can help. But then beyond this, they have to put other inputs in terms of how much they are investing into their marital life matters. So that work also need to parallelly happen. That's where we will be able to handle the tolerance to the medications. But generally, it is the tolerance is not an issue when we are giving a good dose of it, sir.
Okay, Amrit, RK is there.
Yeah, there are three raised hands. Shobhit.
Yeah, briefly, please.
Anurag Bhatt and
RK,
Sharma.
please.
I think this is really a very important topic. Thanks, organizers. And Arun sir, I always, learn from you. But I was really eagerly waiting for this webinar, and I discussed with you earlier. So, sir, I am having 3-4 questions, very short questions. One thing is role of tricyclic antidepressants in ADHD. I was going through literature, and while I was working on this, I found it somewhere it has written that is third line choice after atomoxetine and bupropion and other things you have told. The second question is, I want your comment or your experience and your still I'm learning from you use of methylphenidate in case of ADHD in substance use disorder, specifically alcohol. That's another thing. And the third is like whatever I understood that even those psychosocial interventions and other things, and yes, obviously it's therapists on properties which one has to learn over a period of time when working with ADHD. In today's world, where the world is rapidly changing, what about the prognosis of this? And with this old age ADHD, if we think that ADHD is persisting, these are my questions.
Thanks, Ravi. TCAs, desipramine and nortriptyline have been used, but then their effectiveness is questionable. What we were actually thinking of is in terms of the RSD, the rejection sensitive dysphoria, whether the older agents which we usually used, reboxetine and some of the TCAs which were useful for that kind of symptoms which we used to use in the past, whether they will be useful over here, we need to check, but generally the evidence base is quite less. Number two, about ADHD and substance use disorder, there's one thesis which we did also. During that review, we could find that most often there's no problem in diagnosing and treating these people, and they don't seem to abuse it also. And they are there when we have been specifically looking at the factors for which this is being started and being followed up, it works very well. One component in all these things about therapeutic alliance. Now, from 1970s to till date, if at all one intervention work in psychiatry, that is therapeutic alliance. Nothing works. Therapeutic alliance works better. Like how we have established a contact with clients. There are people who have been on no medicine but want to come and meet us on a regular basis. I don't even know why they want to come, but then the kind of alliance which we had with them, that is helping them. And whether it is transference or countertransference, we don't know, but it works for them. It works for them. So if we are able to maintain a proper therapeutic alliance, then that eventually will help. About your futuristic aspect of adult ADHD. Now, see what happens is there is a reduction in the number of buffers, the community buffers and the family buffers is quite often happening now. Now, if we are not equipped enough to improve our buffer system, eventually we will get more of these diagnoses, whether it is coming as adult ADHD or only rejection sensitive dysphoria or only inattention component. This will always be there. Now, they will always be subclinical. They will not reach to clinical level, and we don't need to start them on MPH, but we need to intervene on various other psychosocial aspects which we talked about, whether it is about procrastination with them or in terms of working with undue perfectionistic attitudes, right? Or even the some of the broad autistic stereotypic works. These things are going to be there, and it's going to be more and more unless we make sure that since we have lost the buffers which were traditionally available, whether we can in different formats, informal mental care could be brought in, whether in schools or in families, that needs to be established. If not, then we will be seeing more and more subclinical symptoms. May not be the diagnosable will be remaining the same, but then subclinical problems will increase.
Thank you, sir. Anurag bhai.
Yeah, Dr. Arun, very nice. Oft neglected topic. You talked about rejection sensitive dysphoria as a core symptom. here also, like in medical college, as I said, we have seen a lot of like adult ADHD guys, like boys, they usually come up like with say substance dependent, and then we go into the core features and we find that they have ADHD, which actually led them to having addiction. In females, especially young females, a lot of time the presentation is like this rejection. But once you talk with them, once you interact with them, this symptoms doesn't persist. It is there. They come to the clinics for that, but that's not exactly that persists inside them. They think about it, but then they're okay with it. So you are saying that this is a core symptom that is there. What I'm saying is ki, from your presentation, I feel it is more of an internalizing problem, whereas ADHD conceptually is more of an externalizing problem. So that being a core symptom, always sensitive to that, remembering, I don't know, I don't exactly agree with that, or obviously I don't know, your comments.
Sir, I don't think I'm not said as that that as a core symptom of the syndrome. It is one of the syndromic in a syndrome. This is one component which is there. It's up to that level, and majority of them present with RSG, right? But even
Yes,
sir,
they do present. But is it being is it that core symptom which you said that this is this is there most of the time? Obviously they present with this, but is it like a part of the adult ADHD spectrum? This I don't know. This I wanted to learn more from you.
Yes, sir. So what happens is there are clients who present with inattention alone. There are clients who present the impulsivity alone. Likewise, people who present with RSG also. Now, RSG is one thing which can be present in internalizing and externalizing. This is something which is very difficult. I completely agree with you. They are present in both internalizing group also. They are present in externalizing group also. Sir, one thing I differ with you is in terms of just because ADHD diagnosis is there, that not necessarily that only in externalizing components will be there. They will definitely have internalizing component also. This is something which I've learned over a period of time, because I also believe that at some point of time. But what happened over a period of time, I'm seeing that these are clients at a very early age being subjected to a lot of negative environmental stimulus, which makes them to have poor self-esteem, poor self-identity, and that results in even RSD in them also. And in this RSD, when it is present, just giving MPH alone is not helping them unless we address it. That's why I brought that as an important component, because generally what is being spoken about is the emotional dysregulation. The inattention and hyperactivity and impulsivity part of it. But nobody talks about the emotional components of it and the rejection sensitivity component of it. They are dysfunctional and they create a lot of dysfunctions. If they are not addressed, we are not able to achieve a complete, the outcome is not that very good. So that's why I wanted it to be brought in this year. But definitely that's not the only symptom. It has to be present along with the other symptom to make this the full syndrome. I agree with you.
Thank you so much. Dr. Shobit, we'll take one question.
So I would like to congratulate Dr. Arun for the wonderful presentation, very crisp, and also the organizers to bring this topic. So actually, this is a very, I think the most fluid concept as far as diagnosis is concerned is adult ADHD. And it's very easy, like if child comes with hyperactivity, it's very easy to diagnose. We have set brain templates for that. And if someone comes with inattention, maybe 20 plus, and florally talking about inattention or concentration deficits, we have templates for that. We'll diagnose the client easily. But in between, this trans-diagnostic confusion happens, and it is very challenging. So myself from CIP, we have been trained from phenomenological point of view. We evaluate every patient, and I feel adult ADHD gives a challenge to us because there is no phenomenology as such, and there are behavioral patterns in that, and the discussion is around that, and they are very fluid. My question here is in context of what Dr. Aleem sir was trying to ask in anxiety in ADHD, because many of the patients which, when we give them stimulants rightly, and they tend to improve. The anxiety tends to improve, depression tends to improve, dysphoria, as you suggested, tends to improve. So your comment on that. And also, the easiest patients which we got were strangely in Dehradun. They'll read up and they'll come to us, see, I am having ADHD, I'm having these symptoms. We give them stimulants and they perform better. So strangely, those cohorts they are doing very well. So these are few of my comments and questions.
Um, um, sure. When there is improvement, it is good. But what happens is some of the older clients, I find it difficult to put them on stimulants because they land up with anxiety after stimulants. And now that is my problem with them. And that's where I'm very cautious in starting stimulant in people beyond 30s and 40s, because the presentation moved from the core ADHD to even anxiety symptoms also. Now, there is one more thing which, again, this is purely on the clinical learning which I've had. The older clients who have been learned to live with their ADHD lands up with you because of some reasons, because of their affairs and other things. They land up with you, and then they find that ADHD is there, and they insist on you on put on treatment, and you put them on. What I had seen is at least 5 of my clients went into depression.
Yes.
And the depression are existential because they've learned to live with that ADHD. Now, when we are trying to correct it, we are correcting everything. Even the way in which they have learned to live with it, we are correcting, which leaves them with an existential crisis. And this is something which I found very difficult to handle, and I have to taper it and stop it. And after a point, like say, in the past 5 years, every time when somebody comes and asks, I will tell them, see, this is bound to happen. You've learned to live with that. Why do you want to change it? Right? If you are changing it, what are you wanting to change it like? So this discussion, this is an add-on thing.
Our approach might differ in midlife, late life ADHD. Yes. Yeah.
And quite a few are coming with midlife and late life ADHD also.
Right. Thank you, Mr. Dr.
Thank you, Shobhit. Amrit.
We'll call it a day. Arun boss is tired. He's been speaking non-stop. The questions are short, but the conceptual issues, phenomenological issues are not easy things. It's not that you just spit out. So it's tough on the brain also, and a lot of things, it hits your brain. So we'll call him again. There are a lot of calls for please call him again, please call him again. So please, Dr. Arun, please tell us that you'll come again. We will invite you again.
You are very popular now.
and honestly, WHO has told that COVID has almost finished. So that's not something which you can hold on to next time when we call you. So it's been interesting. And over to the chairperson for the concluding remarks, and then to Dr. Tufan. So we'll make it short and finish it.
Yeah, I think one point I would like to highlight what I have taken home is that the difference between that inattention and inappropriate attention. So your impaired attention versus inappropriate attention, because say in children we see them as like they do something, they leave it halfway, they go to the next task. We don't see that pattern in adults. But what you said rightly, that the way they pay attention is in an inappropriate kind of thing. Maybe they're after something stimulus which may not be very core part of what they really want to do. So that may be more typical of the adult ADHD is what I understood. So thanks for that particular learning point. And it was a wonderful presentation, and I'll hand over to my co-chairperson for his concluding remarks. Thank you.
Thank you, organizers. Yeah, it was a wonderful presentation. I have learned many things, and think everybody have learned many things from Dr. Arun. It was a wonderful session. Thank you very much. Thank you, organizers. Okay,
Thank you so much.
Organizers.
Thank you so much, sir. Tufan, sir.
Thank you, Dr. Arun. It was a wonderful presentation which I had been requesting you since June. And thanks that today this musing you agreed. Actually, these are the cases which we deal. Some of them, as you told, have been adjusted with that. And once we give a morbid level to them, it may not be acceptable. And maybe in some way we will be over leveling. Procrastination can be a personality type, right? But it added to some other behavioral problem, we are likely to label them that you are having adult ADHD. And many adult ADHD really start in the childhood. They're somehow adjusted, become more manifest when the adulthood comes. That is also case. So one has to be very much careful so that it does not land up in an existential crisis and management issue for the therapist or doctor. Instead of improving, we may impose some problems. One has to be very much careful, right? This is my take, and you have also brought it out in your talk. It has been marvelous. Thank you very much. It's wonderful.
Thank you, sir. Thank you, sir.
So the adjectives won't stop. So
Yeah.
it is wonderful because it's a tough topic. A lot of, it's like Dr. Shobit was very, very cool in the way he summarized. So thank you so much. It was really a tough one and you did remarkably well. You made it very simple, no nonsense, and absolutely very honest about wherever there are pitfalls. And you talked about your concepts, the way you have understood things. That's really commendable. Hari's boss, wonderful in your contribution, in your inputs, and the way you set the stage. Arun was again the senior secretary, the way they should conduct the meeting, not too much into it, but then helping us where we wanted these small inputs. Tufan sir, thank you again for keeping it always short, never trying to be like Alim does, always wants to ask questions. So we had a lot of questions. Actually, we had a lot of questions.
Yes.
And
Yeah.
all the questions, because Alim and we just summarized some few of the questions, and many of the things were covered by you. Had asked those questions, so we did not want to repeat. A lot of questions on the drugs. I think anybody can go and read those up in that. So thank you again. Thank you to we had a bumper audience today. Let me tell you honestly, at more than 383 logins at the peak of 290, and that's remarkable. So thank you again, and we would like to have you again. So good night, everybody. Good night to the Thursday Musings team.
Good night.
Dedicated supporters, followers who always egg us to do better and bring better speakers. And the unanimous decision is you have to come again, and you can't deny it.
Yeah.
Absolutely.
Good night.
Absolutely.
Yeah.
See you again.
Thanks for inviting me.
A pleasure to have you. Thank you so much.
Thank you, boss. Thank you,
Okay.
Chef.
I hope you liked it, Dr. Arun.
Thank you, sir.
Good night to all. Bye.
Thank you. Good night. Good night.
Good night, everyone. Closing the meeting now.